So the current models in place, KCC models, provide financial incentives for attributed patients in the models for 1 year, 2 year, and 3 year death uncensored graft survival. And those payments are made to the KCEs, the kidney care entities, which are the governing bodies over particular KCCs in individual markets. It's a requirement of the model that a member of the KCE, this governing body, be a transplant provider. The definition of who counts as a transplant provider is fairly liberal, and I think that's perfectly reasonable. But it's a fairly conservative way of aligning incentives and, more importantly, aligning care coordination across the physicians and APPs who are in particular KCC markets. This is an opportunity to move beyond just transplant access and 1, 2, and 3 year graft survival into additional metrics focused on evaluating patients for the suitability of referral for transplant, more efficiencies that could be realized in the transplant evaluation and waitlisting process. We propose a novel approach to thinking about how the waiting list should be grown and structured, as well as looking further downstream to the episode of care for the actual transplant itself, the early post-surgical hospitalization, post 100 up to 180 days after the transplant, and then again, additional incentives looking at longitudinal graft survival, even beyond 3 years. So it's a very ambitious project. And I think we try and be clear at the outset that one of the reasons that we're trying to socialize this idea in the community now, both the nephrology community and the transplant community, is because the data that we will require in order to understand where the costs are, where the opportunities for care coordination are, don't exist, or at least don't exist in as robust and uniform a fashion as I think the KCC 2.0 will need in order to assess the risks and opportunities that are available to them in a new model. I think it's one of the foremost issues in kidney transplantation today is ensuring equitable access to transplant. I think there are a couple of avenues that could be taken to try and, first of all, bring greater visibility to, and then ultimately identify root causes and improve upon existing inequities. One is to take the approach that's been taken in the current ESRD Treatment Choices model, ETC model, and identify particular subgroups of patients who are particularly disadvantaged in terms of access to transplant. So one could carbon copy, for example, the low-income subsidy carve out for ETC, and perhaps apply something similar to that in a future transplant-inclusive value-based care model. I think there are other opportunities as well, but this is only a model that works if it serves patients, and it only serves patients if the incentives are aligned not only to improve overall access to transplant, but specifically make a difference for subpopulations of patients who historically not had access to transplant. So I think that can be built in terms of quality metrics, sort of as a gating item. So, for example, a new KCC taking risk in a transplant-inclusive value-based care model might have to meet some certain lower bound threshold of quality metrics, and health equity components could be a part of that as a condition for going on to realize upside or cost savings in a model. There's something very similar to that structure in the existing KCC models. But I think this paper is really designed to begin the conversation. I suspect there's a lot of potential ideas and solutions out there, and our hope in publishing it was to spur the community itself to come up with additional ideas and potential alternatives that we can all look at, turn over, consider, and try and sort through as a community which one is going to best serve our patients. Yeah, this is a complex issue with a very long history attached to it. I trace it back to the mid 2000s, where there was, in my view, a misalignment between regulatory bodies. On the one hand, there was an effort on the part of HHS to try and get transplant centers to increase organ utilization, particularly through using organs, accepting organs from older, sicker donors. And at the same time, there was countervailing pressure from another regulatory body, CMS, that resulted in increasingly stringent thresholds, quality thresholds for patient and graft survival. I believe that these two policy ends are fundamentally in tension. Using kidneys from older, sicker donors will result in worse graft survival. Now, historically, it was thought that this could be mitigated through risk adjustment. That is, through mandatory data collection, one could give credit, as it were, to centers who are using kidneys from older, sicker donors by holding them to lower quality thresholds. Unfortunately, at least in my view, the risk adjustment methodology that was used throughout this process was flawed for a number of reasons that are tangential to this conversation. But as a result, a great many transplant centers ended up in regulatory jeopardy, and they behaved in a very typical way. When they ended up in regulatory jeopardy, they had their commercial contracts come in jeopardy. And they were also subjected to fairly stringent additional regulatory requirements by CMS. This resulted in risk aversion. And risk aversion for a transplant center means two things. One, it means that transplant centers tend to decline organs that they think are higher risk. And they also tend to decline to list patients that they think are medically higher risk. And so we saw very stereotypically transplant centers that were under regulatory scrutiny reduce their transplant volume, as well as reduce the size of their transplant list, even when it may not have made sense for an individual transplant center to behave in exactly that way. There's a whole longer story behind that, but all of which to say, it's illustrative of a system where the incentives are aligned to encourage risk aversion and not encourage risk tolerance. I think we just have to have a grown-up conversation about the fact that if we increase the total volume of organs, and if we do that using kidneys from higher risk donors, then it's just going to be the case that our patient and graft survival are not going to be what they have historically been. The key is what's better for patients, or what's better for particular subclasses or subtypes of patient. And there's an ample literature on this now showing that for higher risk kidneys with a lower expected graft survival, that there are large subsets of patients that would benefit from getting that transplant earlier, in that they'd end up surviving longer with more time off of dialysis, probably with a better quality of life compared to the control, which is remaining on dialysis. One of the problems with these debates over the years is thinking about what the alternative is to accepting a higher risk kidney. Is the alternative, is the comparison group a lower risk kidney, or is the comparison group remaining on dialysis? In my view, the comparison group, the appropriate comparison group, is remaining on dialysis. There was recently a study that looked at 8-year outcomes after kidney transplantation in centers that performed at the top third, the middle third, and the bottom third for patient and graft survival. And then they compared that to patient survival on a transplant waiting list. Even the least well-performing kidney transplant programs in the United States for patient and graft survival conveyed twofold higher patient survival compared to waitlisted patients, who are a subset of patients who are dialysis dependent, who are generally healthier. So I think that's a reasonable trade-off, increasing the total number of organs, accepting a slightly lower patient and graft survival over the long term overall, and getting more patients liberated from dialysis who want to be liberated from dialysis. And so we have to set up an incentive structure, and it will be complex, that will incentivize that without necessarily taking regulatory focus off of transplant centers who do have opportunities for quality improvement. So one aspect of our paper addresses the question of transplanted patients with advanced chronic kidney disease in their graft, that is, patients who have eminently failing transplants. These patients, I think, are ill-served by the system as a whole. It's not always clear who's responsible for their care. Transplant centers, generally speaking, are not well equipped to undertake late-stage chronic kidney disease management, things like anemia management, access discussions, access creation, dialysis modality selection, including conservative management. And so too many of these patients, in my view, return to dialysis undermanaged, often with a tunneled catheter. They have very high morbidity and mortality rates. And I think these are avoidable situations. But to avoid those situations, there needs to be care coordination between transplant centers and general nephrologists. General nephrologists need to be involved in the care of these patients, not all by themselves, and not all out on their own, but in a coordinated manner so that the patient's immunosuppression can be managed and in some cases tapered where appropriate, so that the general nephrologist can have a chance to have discussions with these patients about their renal replacement therapy related preferences and undertake the necessary preparations that has been shown to work in optimal start methodology. There's something in the neighborhood of $1.3 to $1.4 billion a year in avoidable, conceivably avoidable medical spend on patients with prematurely or uncontrolled graft failure with return to dialysis. So there's ample financial incentives to create these care coordination structures, but we should just do it because it's best for the patients. There's a large fraction of patients currently on the waiting list who have previously had a kidney transplant. The way to successfully navigate a patient with a failing allograft back to the waiting list is to ensure that their transition to dialysis, if that's what they choose, is a smooth one, ideally with a permanent access, and for patients for whom it's appropriate, home dialysis modalities. And my hope is that this transplant-inclusive value-based care model will both recognize the value of that care coordination and incentivize it appropriately.